welcome everyone. We are hopefully over the course of the next sort of 45 minutes going to take you through the menopause. We can kind of start at the beginning, tell you all about it, symptoms to look for, what you might experience with the menopause, and then take you through some of the options that are available for managing it and treatment, including HRT, as well as looking at some of the lifestyle options that are available. So I'm just going to start by telling you just a little bit about the menopause and, what you can expect and why it happens. So all ladies will go through the menopause at some point in their life, and it's to do with a gradual decrease in the amount of certain hormones within the body. The predominant ones that cause symptoms tend to be estrogen, progesterone and testosterone, all produced by the ovaries. And this production gradually decreases as all women age, and eventually comes to a stop. For most ladies, the average age of the period stopping and kind of what we call the menopause is around 51, but many ladies can experience symptoms either side of this. And that's a period that we often call the perimenopause. And that can start up to a few years before your periods change or stop, and can continue for a few years afterwards. So ladies will often be experiencing symptoms for a long time, in and around when their periods actually stop. Around 80% of ladies will experience some sort of symptoms, but actually only about 20% will contact a doctor and seek help for their symptoms, and up to about sort of 70% of ladies will actually experience quite severe symptoms of the menopause. So I'm just going to take you through a quick whiz through of what symptoms you might expect. It can affect a lot of body parts. So we know that actually from top to toe, estrogen has receptors all over the body, and therefore you can get a wide range of symptoms. Not everybody experiences all of them, but I'm sure a lot of these will be familiar to you. So starting sort of at the top and working our way down, I know lots of people will be experiencing various sort of issues with brain function, so memory, brain fog. A lot of people describe just not being as sharp as they were before. It can even affect your mental health, so anxiety, low mood. All of these might be new things that you've not experienced before, or worsening of things that you've had in the past. It can affect your hair. It can make your hair brittle, thin, dry. And again, similar with the skin and eyes, you can get quite dry skin. Dry, gritty eyes are really common. Often you get big effects on your weight. So as you go through the menopause, we know that there is an effect on your metabolism, and therefore a lot of people find it harder to maintain the weight they were before, despite not changing their diet or activity levels, and actually struggle to lose weight. Can affect your heart. We know that has quite an effect on the cardiovascular system. So ladies going through the menopause have a higher risk of things like heart disease. Often you can experience palpitations or a racing heart, and these can all be new. Can affect your bowels and your digestive system. Often people find without changing their diet, they can become more constipated or have diarrhea, and that's not uncommon. It can also give you bloating or just general kind of feeling of being quite uncomfortable. It can affect your muscles, your joints, so that sort of aching in your muscles or aching in your joints that you didn't have before. Again, that can be a common symptom of the menopause. As we know, a drop in estrogen can have quite a big effect on your bones. So people are at risk of thinning bones and osteoporosis as they get older, and that can often be due to a lack of estrogen. So ladies have a much higher risk of osteoporosis than men. So making sure that we kind of do the best we can to build up our bones, alongside sort of treatments for menopause like HRT, can be a real help to build up bone strength. We know a lot of ladies find it can have a real impact on their sexual function. So libido can drop during the menopause, as well as having sort of dryness in the vaginal area, which can make sex uncomfortable and painful at times. And again, there are often specific treatments that can help this alongside things like HRT. And alongside that, bladder as well. So we know that some people find that they get an increased frequency or pain when they're passing water, and often that can be due to a lack of estrogen in and around the bladder and the vaginal tissues as well. As I mentioned, there are other risks to overall health for ladies during the menopause and with a lack of estrogen. So, as I mentioned, heart disease is quite more common in ladies after the menopause. Bone health, osteoporosis is a lot higher risk for ladies than men, and we will talk a little bit about bone health later on. Ladies are at high risk of type 2 diabetes, and that can be due to difficulties maintaining their weight, but also as a result of a lack of estrogen. Alongside brain health, sort of studies are showing that there are kind of associations with early dementia and general cognitive decline. And as we mentioned earlier, the mental health side of things, so higher levels of depression and anxiety as well. So I'm going to hand you over now to my colleague, Dr. Glasgow, who's going to take you through sort of HRT from top to bottom.
So I'm going to talk people through the options for traditional treatments such as hormone replacement therapy, and just tell you a little bit more in detail about the different things that are out there and what the pros and cons might be, starting with the 3 hormones that we use for HRT, sometimes which are combined, sometimes which aren't, but estrogen, progesterone and testosterone, as Amelia's told you a little bit about, the benefits of that, some of the risks that are associated with it, and try and dispel some of the myths that we've got. The treatment options, and hopefully answer any questions that people might have as we go along. So the reasons really for considering HRT, the main reason that people come and see us and often seeking advice is to manage or relieve the symptoms that they've got, and that can be either of the menopause or of the perimenopause. There is also evidence that HRT is very beneficial for bone loss, and it's actually a first-line treatment option for women with osteoporosis, so thinning of the bones or reduced bone mass. It's a really important treatment for women who go through an early menopause, now called failure of your ovaries or premature ovarian insufficiency, and it's thought to be most effective if it started within 10 years of a woman's actual menopause. But often women don't know, given that they might be on other treatments that stop their periods, and they don't know when their menopause is. And it's probably fair to say it's never too late, but the earlier it started, probably there's more long-term benefit. There aren't really many reasons why women can't have hormone replacement therapy. Clearly, if you're pregnant, it's not an option, but you can get pregnant while taking hormone replacement therapy, and sometimes we actually offer that to ladies who are having fertility treatment. If women have got ongoing unexplained vaginal bleeding, so they don't know why they're having bleeding, they need to be investigated first before they start on HRT, but it doesn't mean to say if they've had bleeding in the past that they can't have it. If they've got either suspective or active breast cancer, or even cancer of the womb, as we call it, the uterus, then we would avoid hormones at this time. And there are some conditions with the liver. Not all liver conditions mean you can't have HRT, but they need to be discussed in more detail. So the 2 main hormones that we prescribe initially for women, if they have a womb, so if the womb is still there, they haven't had a hysterectomy, is estrogen, which can be given in the form of a tablet, a patch, a gel or a spray, and progesterone, which is generally given either via a coil or an IUS, intrauterine system, or in tablet form. Sometimes it can also be given in patch, but less often these days. So if women have had a hysterectomy, they've had their womb removed, they do not need the progesterone arm of hormone replacement therapy, and then we're just giving them estrogen, as I say, pill, patch, gel or spray. So progesterone, this is taken alongside the estrogen, and if women have a womb, it's imperative that they have progesterone alongside it because it prevents the lining of the womb becoming too thick. There are different types of progestogens, synthetic, so ones that are artificial that are made in a lab, and they're often the ones that are found in the combination patches and the tablets. The safest type of progesterone from the evidence in the long term is something called micronized progesterone, and that comes in capsule form, and that's called Utrogestan. There's quite a lot of publicity about this at the moment because it's quite difficult to get hold of because the supply is being outstripped by the demand. Depending on whether ladies need to have a bleed, so whether they have stopped their periods naturally or not, will depend on whether they take it continuously or whether they take it in a cyclical way, so for a number of days in their cycle and then stop for a number of days, quite commonly 2 weeks on followed by 2 weeks off. It's thought to be fairly natural in the sense that it's derived from the yam vegetable, and it is identical to the progesterone that we produce in our bodies. The other main alternative that often women get offered, particularly if they need contraception, is the Mirena coil. That's the intrauterine system that it's sometimes called. That releases a steady dose of progesterone for a 5-year period and, as I say, provides contraception as well. So the other arm, or the other main arm, is estrogen itself. We use generally a transdermal form, which is identical, again derived from yams. There is a tablet form, and this is perfectly fine for some ladies to take, but however, that is synthetic, and sometimes people have slightly more side effects, and there's sometimes very specific reasons why we try and avoid oral estrogens. The gel is given in the applied at the upper arms or the inner thighs. The patch is applied to clean, dry, non-bearing, hair-bearing skin, which is generally below the waist, either at the front or the back. And the spray, more new an option, and sometimes not as consistently absorbed by ladies, but that can be applied on the inner forearm or the inner thigh. So testosterone, there's a lot of chat about testosterone, and it's by no means absolutely essential for women to receive testosterone placement just because they're having hormone replacement therapy, because not every woman needs it. But testosterone is produced, as Amelia said, in female bodies as well. It's produced by the ovaries, and in fact you produce more testosterone than estrogen. As I say, not all women need it. It can be prescribed on the NHS or by a specialist, but a specialist needs to advise it or initiate it first. And it needs to be only considered if people have got a low libido or low sex drive. There are other benefits from it, but there needs to be that in order for us to be licensed to prescribe it. The product that we use in the UK, unfortunately, isn't formally licensed. So we need to use a male product, which we use a significantly lower dose than we use in men. And that's why we need to monitor it. So normally we do a baseline blood test before starting. We do one at round about 2 or 3 months, and then usually an annual test. We want to keep it within the physiological range for women, and that reduces the chance of any side effects. There's quite a lot of evidence going on at the moment which has shown quite good improvements in women's mood and also in cognition, so brain function, and sometimes the brain fog that women describe doesn't fully respond with the estrogen alone. It's very clear that if people haven't responded within 6 months, there's no evidence to say there's any value in carrying on beyond that, so we would stop it at that point. So, what are the main benefits of hormone replacement therapy? Why would women want to take it? Well, hopefully to improve the symptoms that they're having, but also from a long-term point of view to reduce the risks of some fairly significant health conditions: osteoporosis, cardiovascular disease, type 2 diabetes, cancer of the colon or the bowel, and as Amelia said, we think probably dementia as well. Risks is something that's really been talked about a lot, particularly in the early 2000s when a big study came out of America. But the majority of women under the age of 60, the benefits of hormone replacement therapy are likely to outweigh any additional risks that are associated on it. Those risks very much depend on women's personal medical history. They depend on whether women have a womb or not. And they also depend on which type we choose. So that's a discussion that women can have with their physician to make a decision about which is the appropriate type for them. So going specifically into some of the risks, breast cancer is a big concern for women. 1 in 7 or 8 of us in the UK will develop breast cancer in a lifetime. Unfortunately, we don't know which one of which of us that's going to be. And we know that studies have shown that there's a lower risk of women developing breast cancer if they are on estrogen-only hormone replacement therapy. We can't exactly explain why, but we've got very clear evidence to say that happens. Certainly in the 5 years of taking hormone replacement therapy, there isn't an increased risk of developing breast cancer. We also know that there are very many other lifestyle factors that influence women's risk of breast cancer, being overweight, drinking more than 2 units of alcohol a day, and reduced exercise. So there are things that we can do to, which Meg will come to reduce our risk of some of these conditions as well, alongside what medication we put in our bodies. As I said, exercise, more than 2.5 hours of exercise a week does reduce risk of developing breast cancer. Blood clots is another thing that we know can be related to hormones. We know that the combined contraceptive pill that we give very regularly can cause blood clots, and in fact the risk associated with HRT is lower than that. If we give the estrogen through the skin, so we say transdermal, it avoids the increased risk of clots. And so that's really important that people know, even if they've got a family history or a personal history of having had a thrombosis or a blood clot, they can still be considered to have HRT. The other thing that's important is we know that clots and migraine can be associated, and even women who've been told they can't have the combined pill because of their migraine history can in fact have hormone replacement therapy, but we would advise that estrogen would be given through the skin. Blood pressure is something that we always do an annual review for HRT, and in the past we've always thought that if people's blood pressure was high, or that if their blood pressure was high on review, that it was made worse by the hormones. In fact, we've got quite good evidence that the route of estrogen through the skin can actually lower women's blood pressure. We don't think that the progesterone pill that we give, which is body identical, has an impact on blood pressure at all. And as far as blood pressure and heart disease, we know that long term it reduces the risk, and actually HRT has been shown to lower people's cholesterol. Side effects are relatively uncommon. If they are going to happen, they pretty much happen in the first few weeks or months. People complain of sickness and nausea. Breast tenderness is a very common side effect. If it does happen, it usually settles. Sometimes people complain of stomach bloating and stomach cramps. Leg cramps is something that's in the literature, but not something that I've seen personally. Sometimes women, if they've had problems with migraine and headaches, get an increased frequency or an intensity of their headaches, but it isn't a reason why they need to stop the HRT. And sometimes people can get local irritation around the site of the patch if they're applying patches. In addition to the hormone replacement therapy I've mentioned before, we can also give estrogen locally to the vagina, and this sometimes is an option for people who can't take systemic HRT, so gel, patch, tablet or spray. And local estrogens are used in the vaginal tissues for vaginal dryness, if there's any discomfort or burning, if people are having pain on intercourse. It can also be really helpful to the bladder and the urethra, which is the outlet tube for the bladder, and can sometimes reduce the risk of urinary infections and even reduce the risk of urgency and incontinence. It can be applied to the vagina in different ways: creams, little pessaries, little tablets that get inserted, or a ring that can be popped in either by the patient themselves or by their GP or nurse and exchanged at a 3-month interval. It is totally safe, and even women who've had blood clots and even women who've had breast cancer in the past can take local estrogens, and it can be taken for many, many years. It's probably something that we've undervalued and underappreciated, and it's something that we should really be encouraging women to do in the long term. So commonly asked questions. Lots of people ask me which they should choose. Is there a better one? Tablet, patches, gels or sprays? It's really very much individual, and it's very much about what people's routines are. Do they want something that's every day, like a tablet or a gel, or will they forget something that's every day and they want something less often, which is like a patch, which is twice a week? And there are some specific medical reasons, as I mentioned before, why we'd want it to go through the skin, so we would avoid tablets, but that can always be discussed. But to be honest, you can take it in various different forms very effectively. The gel and spray, I think and the patch I've mentioned where you put it already. A lot of people wonder whether or not they need their blood tests doing. Once women reach the maximum licensed dose, if we want to increase their dose further, sometimes we want to check what the levels are doing in the blood just to see if they're a poor absorber, because there's huge variation in the dose that women absorb through their skin. Sometimes people aren't quite sure what to do if their symptoms return having started the HRT, and we'd always say go back to your practice or the person that's prescribed it to you and discuss about altering your dose. People often ask how high a dose of HRT we should give. There is huge variation nationally and internationally about what people feel comfortable giving, and there's a bit of debate about that at the moment. But generally, we prescribe within the licensed dose. When do I need to stop my HRT is another common question. There's no age at which you must stop HRT or it's dangerous to take beyond, but we would always discuss it and we would try and reduce people's dose if they didn't need as much. We think probably as we get older, we don't need as high a dose as we do in the perimenopause and the early menopause stages. Sometimes people are not unreasonably asked what to do if they forget. If they forget the patch or spray, take it as soon as they remember, but I was always advise that they keep to their routines. If they normally change their patch on a Monday or a Thursday, forget the patch, stick to the same days and just have a patch on for slightly less time if they forgot it.
Thank you, Louise. Hi guys, so my name's Meg. I'm a GP in Nottinghamshire and also lifestyle medicine specialist. So just wanted to have a little chat with you guys about the role of lifestyle and lifestyle changes that we can make in the menopause to help with symptoms and risks. We've obviously covered the sort of medication aspect and looking at the medication that we can prescribe to reduce symptoms and improve bone density and things like that. But actually there's a lot that we can do ourselves as ladies just in our everyday lives that can make a really big difference. And I think it's important to realise that lifestyle is not an either or an or situation. Actually, it should be used as a combined approach, really. Obviously, for some ladies, HRT might not be possible or appropriate, but more than often it is. But lifestyle should really be considered with equal importance. And long-term conditions such as heart disease and stroke and diabetes and things like that are also significantly reduced if we adopt some of these measures that I'm going to talk about. So it has a widespread sort of benefit, if you like, is not only reducing our symptoms and the difficulties that women encounter during the menopause and the perimenopause, but also reducing your risk of disease and improving your lifespan and health further on. So I think the important thing to mention as well about HRT is that sometimes HRT actually helps so significantly that it can allow women to then be able to make lifestyle changes that they just didn't feel able to tackle beforehand. And it's perfectly reasonable actually when suffering with so many of the symptoms as some ladies do, that they just don't feel able to tackle some of these difficult things that they're hard for us to change our behaviours, aren't they, sometimes? And taking HRT, which massively reduces some of our symptoms, just can sometimes open that door and allow us to make other changes which have other benefits. All of the things I'm going to talk about today have good evidence base. They are rooted in science and studies, and so there's good evidence for them, and I'll talk a little bit about some of the evidence, but I won't go into too much detail. So one of the first things I wanted to tackle was physical activity, and I put a little link down here which you guys might want to just take note of, just as a simple set of sort of exercises and things that we can just do at home. I think one of the biggest barriers to being physically active is sort of just not knowing where to start a lot of the time. Some of us might have been more physically active as younger women, but has tailed off as we've got older and haven't been physically active for a very long time, and just not really knowing what to do or where to start, because thinking, well, you know, I can't go out running and I can't play squash like I used to when I was 20, and that's completely reasonable. But actually there's lots of things that we can be doing that are really accessible. So this link that I put down just gives a little sort of set of exercises that can be done in your own home or kitchen in just 5 minutes, and it was championed by Dr. Chatterjee, who was the sort of doctor in the house, doctor who was on television a few years back. So well worth taking a little look at those. I think one of the most significant things that we can do around the menopause and the perimenopause is actually any physical activity that involves moving our body in terms of moving our own body weight. So strength-based stuff, and that doesn't mean going to your local gym and trying to pump iron with all of the bodybuilders. That's not what I mean at all. But a lot of the exercises that you'll see on that little link there are body weight exercises, where maybe you're pushing your own body weight against gravity. So it might be doing some squats and then standing up, or it might be pushing ourselves away from a wall or a desk or a chair, lifting things that work our muscles. And the reason that's so good for us is because it builds up our muscle and our bone strength, more importantly. And I think Amelia's going to talk a little bit more on bone health later, but it has really big impacts on your bone health, which is key for ladies who've gone through the menopause, but also has lots of mental and emotional health benefits as well. We know that moving our bodies and getting exercises really improves our mental well-being, even if we don't feel like doing it at the time. Afterwards, we get that endorphin kind of rush, that flush of good hormones, which help us to feel better in ourselves, more energized actually, and more invigorated afterwards than we felt before. So it can really be quite stimulating if we're feeling quite tired and fatigued, perhaps sleep deprived, and there's lots of reasons why we might be feeling quite tired. Actually, physical activity helps with that, so important to bear that in mind. And I think just in terms of simple tips, everybody will be different in terms of the sorts of physical activity that will work for them. So for some ladies, it may be that they've always had a passion for a certain activity. It might be cycling or swimming, something that they used to do when they were younger, maybe haven't done so much recently. But it will vary from person to person. And the key is really just finding something that you love or that you really enjoy, because it shouldn't be a chore and a challenge. It's hard enough to get ourselves motivated without doing something we really hate. So finding something you really enjoy and starting really, really small and building up gradually. So not just going out and trying to run 5k when we haven't done any sort of physical activity for 10 years or so, but actually starting something small with just a 10-minute power walk each day on our lunch break or something like that, and just gradually building up, because that makes it much more accessible and something that we're more likely to stick with, rather than going all out, finding it really difficult and then sort of giving up and thinking, oh, maybe that's not for me. So gyms and weights might be really unfamiliar, and that's why this sort of kitchen workout, something you can just do at home. You don't have to pack any special equipment, you don't have to change, you don't have to have a shower afterwards. You can simply do it while the kettle's boiling or while the bath's running or whatever it might be. So it's removing some of those barriers that we might find are in place when we're thinking about physical activity. And one of the other key things around doing physically active work during the perimenopause or after the menopause is actually body weight. And a lot of ladies are feeling that they're not in the greatest of shape, might have put on a little bit of weight over the preceding 5 or 10 years, be heavier than they would like, and actually find that to be quite a barrier to physical exercise, which is completely reasonable. So I think starting at home in a position where you feel more confident and more comfortable, you're not out in public, is a really good way of just starting small and building up your confidence with things. The other issue that ladies often complain about is pelvic floor, and pelvic floor and incontinence can be a real problem during the menopause. And so that can be a problem during some exercises, and I guess things that involve lots of sort of difficulties with holding in our pelvic floor, like running and impact exercises, might be quite challenging initially. We might want to start with other things like swimming or cycling that are lower impact if that's a particular problem, whilst seeking some support, doing some strengthening exercises. There's a really good app that's an NHS sanctioned app called Squeezy. We'll try and get some links attached on the Partners Health website. And that's a really good kind of at-home physio that you can do for your pelvic floor, and it tells you exactly how to do the exercises. You get reminders on your phone, and it's brilliant. Little sort of workout routine that you can do to really strengthen that pelvic floor, and that's really key to just comfort and also being able to do these sorts of things more regularly. So that's a few little tips. Physical activity is really, really important. The next thing I want to talk about, which I'll try to keep brief, but I could probably talk about it for hours and hours, is nutrition. So the role of diet and nutrition has a bigger role than you would think. A lot of people wouldn't imagine that actually what you eat or how you eat had any impact at all on your hormones or menopause. A lot of people, when they think about diet during the menopause, are thinking about dieting and how to lose weight, and that's not really what I want to talk about at all. It has a really big role actually in hormonal metabolism and how we process our estrogen and how that relates to the symptoms that we get. And the evidence shows that if you can have a diverse, so a wide range, a wide variety of plant-rich foods in your diet, you are more likely to have improved symptom control, so less likely to suffer with troublesome hot flushes and brain fog and better sleep. So it has a wide-ranging impact. There's lots of reasons why that's the case, but the main reason is that it significantly improves the number of friendly gut bacteria that we have. So the more plants that you can eat and the more variety of plants you can eat, the better groups of bacteria you have in your gut. And the importance of those bacteria that they decide which hormones that we metabolize, that we produce or that we absorb in our body. They decide how our metabolism works, so how much energy we burn on a daily basis. They also decide what chemicals our brain releases and then what our mood is like. So those gut bacteria actually have a really, really significant role in deciding how the rest of our body functions. And we didn't realize that, 10 or 15 years ago, and we're only just realizing now the role that they play and how much of a role they play. And they are very, very keen on high fiber foods. And we find fiber in plant foods. So the more fiber that we can get in our diet and the more variety of different plants that we can have, the better a kind of culture of organisms that we will develop and we will grow in our own guts, and the better our body will function. So when our estrogen levels drop during the perimenopause, that can actually have quite an inflammatory response. So our body becomes more inflamed than it was before. And a diet that reduces inflammation is really key. Fruits and vegetables and greens and all the things that your mum and your gran told you to eat when you were younger, or all the things that contain lots of really good compounds, lots of important plant chemicals that help to balance out that inflammation. So they act as an anti-inflammatory force in our body, and this improves all of those symptoms, as I said before. The key one really is probably our brassicas. So brassicas mean broccoli, cauliflower, cabbages, kale, those kind of bitter greens and those bitter vegetables that the reason that they're so powerful and the reason that they're so beneficial is actually because of that bitterness. The bitterness tells us that they've got all of these helpful plant chemicals in them. So bitterness and bright colours are usually a key as to whether or not a plant food is going to have lots and lots of those phytochemicals in them. And the more of those that we can pack into our diet, the better. It also actually improves, fibre is really important for improving how we clear estrogen through our gut. So as we break down estrogen, the hormone, as it gets used up in our body, and we break it down, it gets released into our gut in lots of little pieces, lots of little building blocks. And when we don't have a nice regular gut transit, so when we don't move our poos on a regular basis, for example, those little breakdown products of estrogen actually get reabsorbed back into the body. And you'd have thought, well, if I'm reabsorbing my estrogen, then that's a good thing, because most of my symptoms come about because my estrogen's low. But actually what happens is that we get fluctuating levels of estrogen because of this reabsorption, where we're sort of breaking it down and then we're suddenly reabsorbing a load, and levels are going up and down like this. And often in the perimenopause, it's the yo-yoing levels that our body finds really difficult to deal with, rather than just a nice stable low level. And if we can have more fibre in our diet, and we can have a nice regular stool habit, more fibre means a nice regular gut transit, we actually reduce that variability in the estrogen, and we actually see reduced symptoms. So that's why the fibre is kind of key. Talked a little bit, or touched briefly on the fact that weight is often a problem for ladies around the perimenopause, and weight management and weight reduction is often a key goal for many ladies, which is understandable. Lots of women will find that they've tried some very restrictive diets where they're really eating not very much at all, or they're really massively restricting what they're eating in an effort to lose weight and to get back to their sort of weights that they recall being when they were younger. But actually, energy intake's really important to keep your balance, to keep your energy balance in check. So what we often find is that when ladies are massively reducing their intake, they just don't have any energy. They don't have enough, not taking on enough calories to really have enough energy to function properly. And fatigue is such a big issue around the perimenopause. Actually, we often find ladies are just making that worse inadvertently by massively reducing what they're eating. So eating regular and frequent small meals that are rich in plant foods, which are naturally quite low in calorie, but making sure that you're really eating good amounts of those is key for balancing out your energy throughout the day and not having these sort of big dips and fatigue crashes. A couple of other tips: actually a slightly higher amount of protein around this time can be helpful. As I said before, the evidence shows that a more plant-rich diet is better for ladies around this time, or just for health in general. So if you can look for more protein, more plant-based sources of protein to increase, that's great. And those would be things like legumes, so our beans, lentils, chickpeas, nuts and seeds are high in protein, as well as edamame and soy-based products like perhaps tofu. Quinoa and whole grains are actually quite rich in protein, quite high in protein. Even just whole grain like oats is about 10% protein. So thinking a little bit about protein sources during this time can be helpful. Calcium and vitamin D are important micronutrients to think about. We've already talked a little bit about the importance of bone health, and Amelia's going to touch on that in a little bit more detail. Calcium we can get from leafy greens, particularly lots of leafy greens. Already talked about the importance of that, but that will boost your calcium levels. But if you're not a big kind of dairy drinker, using plant-based milks that are fortified is key, and looking for other fortified foods. Lots of cereals are fortified with calcium and things, but just paying a little bit more attention to that is helpful. Vitamin D we get from the sunshine, and we can get that best between around May and September in this country. We actually don't get enough strong sunshine the rest of the year really to produce enough vitamin D. And I often encourage ladies to take a low dose of vitamin D year round, actually to additionally supplement their intake. And iron is a key one, which again I would encourage people to get from plant-based sources. You can find some more sources of that on the NHS sort of NHS websites, but leafy greens are one of the key ones for iron. So the kale and the collard greens and those sorts of things. There might not be things that you're eating now in significant quantities. We often don't eat a lot of those in this part of the world. So thinking about ways of increasing that is really useful. Things to reduce alcohol, which is controversial, especially around this sort of time. Lots of ladies around the perimenopause might be drinking on a reasonably regular basis as part of their sort of social meetings, social groups, and as well as just regular sort of drinks at home. But actually alcohol can have a significant impact on both sleep and also what we call the vasomotor symptoms, which means that your flushes and your sweats, the hot sort of sweaty symptoms that people get, and alcohol can make those worse. So if those are particularly problematic, actually reducing alcohol can make a significant difference for some ladies. And caffeine and smoking have a similar effect on those things. So if you are smokers looking to sort of finally reduce that and stop if possible, using various support networks in your area, which the GP can talk to you a little bit more about, and reducing caffeine if possible. So switching maybe from a caffeinated coffee or a tea to a decaf, and things like Coke and fizzy drinks often have significant amounts of caffeine in them without people realizing. So just being aware of your caffeine intake, because it makes a big difference actually for the flushes, sweats, and particularly sleep. The other one, just to briefly touch on, is water. So hydration is a really important part of reducing your symptoms. And often around this time, ladies are really struggling with symptoms. I've talked a little bit already about pelvic floor and incontinence, and people are often starting to think about their bladders and whether they'll need the toilet, and might even be restricting the amount of fluid they're drinking to reduce the likelihood of having accidents or needing toilets in difficult places. But actually hydration is really important. So if that is an issue, if pelvic floor and the bladder symptoms are such an issue that you're actually reducing your fluid intake, it might be that you're making yourself a little bit more dehydrated, which will be making the other symptoms like brain fog and fatigue and concentration and flushes and sweats a lot worse. So speaking to your GP about how we can manage the bladder symptoms could be really, really key, so that we're not restricting fluids unnecessarily. I was going to touch just briefly on complementary treatments. There's so much information out there, it can be quite difficult to tease out what's beneficial and what isn't, and lots of people might have heard, oh, this is great, and my auntie tried this and swore by it. Actually, the evidence is very low grades, low quality. So if there is any evidence for benefit with some of these supplements, it's very low level, and it isn't something that we would generally go out and say we would actively promote. But there is some evidence for particularly sage, black cohosh and St. John's wort for a couple of the different symptoms of the menopause, particularly the flushes and sweats. So it may benefit some ladies, but it may not benefit others. The thing I would point out is that most of these are unlikely to cause significant harm. So if ladies wanted to try them or were already trying them and found them to be effective, generally speaking, that would be fine if you wanted to try them, but that there wasn't enough evidence for us to say definitely that's going to be helpful for you. The only thing to bear in mind is if you're on any other medications, particularly St John's wort, but some of those other ones as well can interact with medications that you're on, and it's important just to let your doctor know that you're taking the supplement or that you're thinking of taking the supplement so that they can make adjustments if needs be. Sleep, which is a massive issue for lots of ladies around the time of the menopause. Even if you're not getting hot flushes and sweats that are keeping you awake at night, sleep is often still disrupted, and ladies will find that they're waking regularly in the night, or they're finding it harder to get to sleep. They may suffer other symptoms like restless legs. They may suffer a little bit more anxiety, which may be affecting sleep as well. So there's lots of reasons why sleep can be impacted. Also perimenopause and menopause comes at a time where sometimes ladies have got lots of other life stresses going on. Work is difficult, or children are older and needing more support maybe, and elderly relatives are needing more help. So all of this can impact sleep. And the hormonal fluctuations often just result in much lighter sleep and frequent waking. People often find they're very sleep deprived, and that makes a lot of their other symptoms harder to manage. So things like your mood, which is always worse when you haven't had enough sleep, and also memory and recall and concentration is worse when you haven't had enough sleep as well. So it can be hugely impactful. There are some things which help with sleep. I think the hormonal fluctuations around this time actually are really significant, and not all of these techniques will be as effective as one might hope, but they're certainly important things to think about if sleep's an issue. So one of the key ones is making sure that you get more natural light during the day. So as early on in the morning as you can, and by natural light I mean sunlight or daylight rather, from a window rather than a light bulb. And that might be as simple as getting up in the morning and going and eating your breakfast by a window. So it doesn't even need to be anything significant. But maybe if you normally eat, by your desk or in a dark room, actually just taking your breakfast and sitting by a bright window and having your breakfast there, so you get a good hit of light early. And what that does is it helps to regulate your body's natural waking and sleep rhythm called the circadian rhythm. And it tells your body, right, it's time to be up now, and it affects your hormonal modulation. So the more natural light you can get in the day, the better, and the less artificial light you can expose yourself to in the evening or after the sun has gone down, the better. So not confusing your body by having lots of bright lights on in your lounge or your living room, or having your laptop on late in the evening, or televisions or mobile phones by the bed, because what that does is it tells your body that actually it's still daylight, because it's confusing. We call it blue light, the light that's emitted from electronic devices. And there are some ways of reducing that, whether you use special glasses, yellow tinted glasses, or you can have apps on your phone or your laptop that change the lighting. But actually limiting it as much as possible is key, and keeping your light levels in your house low. Your bedroom, there are changes you can make in the bedroom, and most people will have tried these sorts of things, but making sure the room's as cool as possible. And so it's fine to have good sort of heavy duvet and sleep with bedclothes, but keeping the actual air in the room very cool is key. Full darkness as well, so making sure that you've got blackout blinds or good blinds to prevent yourself being woken early in the morning by the sun is simple and fairly important. And making sure you've got a useful wind down routine. So for some people this might be that they have a set bedtime and about an hour before they do things that help them to relax and unwind. So not scrolling through news feeds that might be stressful, or watching thriller movies, or getting into heated discussions with relatives, but having something calming that you do regularly that gives your brain those cues that now it's time for sleep. You do them every day, just like you would with a child, for example. It has good evidence, and it's important to try. The other one I wanted to touch on, which actually is probably one of the most important, but we never give it that much credence, is relationships and stress management. Has a massive impact on so many things, and menopausal symptoms is not any different. It does have big impacts. We find the evidence shows that those that have got complex and multiple healthy social relationships have a much easier time through their perimenopause than those who are more isolated or who have more conflicted and difficult home relationships or relationships with friends. So that's not always easy for everyone to make changes to. But the perimenopause comes at a really challenging time. You know, there's this real loss of enthusiasm, and lots of people talk about just feeling very stressed and anxious, and not feeling themselves anymore, you know, not feeling like they're in charge of their own bodies and minds. They can lose confidence. They can find it difficult to cope with situations actually that they would normally have excelled in, whether that be professionally or at home. They often have multiple caring responsibilities. We know that women do the majority of the unpaid care work in this country, so caring for children and relatives. And it can massively affect their jobs and their family lives. So actually the perimenopause can have a significant impact on relationships and feeling stressed. And so self-care is really important and often gets a very low priority by ladies who, as I've said, at this time in their lives are often managing so many different things. They've got so many balls in the air, they're juggling so much that they'll often put themselves at the bottom of that list. But prioritizing self-care and fostering good, nurturing relationships, whether that be with a partner, whether it be with family members or a social group, whether it be finding a community in your village or your area that have shared interests, just carving out a little bit of time, even if it's just one evening a week that's just for you, where you do something that is just your passion or your interest, can be massively impactful, both on your mental health, on your physical symptoms, and not to be underestimated. Where that is already in place, but maybe ladies are still really struggling with their self-identity or stress symptoms, actually counselling and talking therapies can be hugely important and really helpful too. So counselling's technique called CBT, which is cognitive behavioural therapy, can be really useful. But I think worth acknowledging that can be difficult to access and in a timely fashion in the NHS, but there are other ways of accessing it, whether it be through employment assisted schemes or through part self-funded schemes as well. So worth bearing that in mind. There's loads more information about lifestyle and how it can be impactful, and I think I've spoken to the social prescribers about providing a leaflet that we've got here, which should be in a link somewhere for you to have a bit more of a delve into at your own time.
So last little bit, I'm just going to do a bit of a talk about bones and bone health. I know we've touched on it with the others, but hopefully this will just give you a bit more information about how to kind of maintain your bone health, because as we know, it's really important during the menopause. It's one of the big things that can be affected by estrogen, and actually ladies are a lot more affected by osteoporosis and thinning of the bones than men will ever be. So it's really important for us. Women generally, or people in general, will reach their maximum bone sort of density by the age of 30. So obviously that's a lot of people don't really realise that. So it's important to start as young as you can. Estrogens help to maintain the thickness of bones. So obviously as you get older and your estrogen levels reduce, the bone sort of density reduces, your ability to kind of make strong bone reduces as well. During the menopause, your bones can therefore become thinner as your estrogen levels drop off, and this can leave you at risk of things like fractures and breaks as you go forward. And almost 1 in 3 women over the age of 50 will have a fracture at some point without taking action. So how do we maintain healthy bones? So as Meg touched on, a lot of it's through diet and vitamin D. So vitamin D, as she said, you get from the sunshine. Unfortunately, we live in a country where we don't get quite enough sunshine. We do have some months of the year where we can get enough, being out in the sort of midday sunshine between 12 and 3 in the summer months, you're going to get enough vitamin D. However, over the winter months, even if you were out every hour of the day, you probably wouldn't absorb enough vitamin D. So supplementing with a low dose supplement, as Meg mentioned, can be helpful to just keep your levels topped up over the year. The other building block for your bones is calcium, and that alongside vitamin D is used to build thick bones. Calcium, as Meg said, you can get in your diet. I've included a little link there to the Royal Osteoporosis Society website. They've got a really good calculator to look at the sources of calcium that you already have in your diet and how much you're getting, and then you can see if there are areas where you can improve. So it's worth having a little look. And they also go through a lot of the foodstuffs that you can get calcium in. As Meg mentioned, leafy green veg is a great source. Obviously, if you don't have dairy in your diet, any of the plant-based sources of milk are fortified with calcium. Things like tofu, soya, all of those also have a good source of calcium. And incidentally, they also contain some estrogen mimicking compounds, so actually can sometimes help with your other menopause symptoms. As Meg discussed, weight bearing exercise, strength exercise, so anything where you're pushing your body weight against gravity is going to be really good for increasing your bone strength and your muscle strength, which in turn can protect your bones. So all of those exercises that Meg talked about are going to be really helpful to just maintain your future bone health. If you smoke, that can worsen your bone density. It can make your bones thinner, and it can affect your absorption of calcium. So actually reducing or stopping smoking can be really beneficial to your bone health long term, and that's regardless of whether you're menopausal or not. And again, alcohol has a similar effect, so reducing where you can is going to have a long-term effect on your bones. So that's the end of our sort of chat today. Hopefully you've kind of got enough information and everything that you were expecting to hear. We will be running menopause groups, which hopefully you will have booked onto if you've seen this information. But if not, have a chat with your GP about discussing the menopause with either them or in a group setting.